here today. We got another episode of Drop the Mic here, and we have a really special guest for you. We got coming to you from Denver. It's unfortunately snowing. It was both like 38. Jim, it was about the worst weather possible this morning. It was 38 degrees and raining. Um, I know it's not like that in Santa Monica. So
No, I'll skip the blue sky and sun that we have right now and let you tell us more about the snow.
I don't know that there's much to tell other than that it's freezing rain turning into snow, so it's not pleasant. Jim, obviously, so guys, this Jim Jusko is a really good friend of ours. We were lucky enough to be introduced through our connections at Health Rosetta. Sean actually introduced us, and Jim has a really interesting company. We've worked with him on a couple projects in the past and continue to work with him called FireLight Health. And Jim has a pretty interesting background. He actually is an attorney by trade, then became a Hollywood producer, and now he's forayed his way into the healthcare space in addition to, moonlighting as a professor at UCLA as well. So pretty diverse background.
Well, thanks, Mike. I'll tell you the one thing, though, that has actually helped with all the hospital price data. As an undergraduate, I was a math major at one time. So everything comes full circle in life.
And remind me, you went to UCLA for undergrad and you went to Cal for law school.
Yes, I'm a kind of a California guy through and through on the education, but University of California has done me well.
That's great. Yeah. So why don't you tell us a little bit about like your journey? Obviously, it's a pretty unusual one. So help us, just walk us through. Okay, you're a math major at UCLA. How did you wind up going from that to being an attorney?
I got tired. It's really my whole life is a story of short attention span. I got tired of numbers, and it wasn't just the numbers. Honestly, it was, I kind of looked around at the other students and thought, are these my future colleagues? Is this me? And I thought I need something that doesn't involve numbers at all. And law was always kind of interesting, and all the things it implies about policy and issues. But in law school, I was definitely focused more on business. And when I practiced, I never spent a day in court. It was always contracts, often financing and deals and all those aspects of business. So I learned business through being a lawyer. And then one day kind of thought, gee, it'd be more fun to be a client, maybe for me, than being the lawyer working for the client. And, I'm living in LA, so there were opportunities in the entertainment business, and that's always fun, especially when you're young. So I dove into that, and then even became a salesman, doing international deals to put independent films together. Still a lot of deal work. And that deal work was always about looking through contracts and making sure you can track where money is going and making sure people are doing right by the people who are parties to it. Flash forward years later when I've had fun, but maybe kind of, the fun ended a little bit in showbiz. And my wife has been for more than a decade a patient bedside care nurse at a big hospital here in LA. And, you learn something from 10 years of conversations about how healthcare works. And it always nagged at me. And so it nagged at me enough that I started looking at the fundamental underlying economic issues that we've talked about. And there's plenty of them in healthcare. And that's what brought me to the doorstep of, gee, what could be useful to do? And then I read an article one day about how prices might become available. And I thought, oh my goodness, no one cares about prices in healthcare? And I looked more closely, and I'm convinced that most parties have arranged it for themselves where prices don't matter that much. Only a couple people worry about prices. Me and you.
And a few of the other benefits consultants on this call are
Absolutely. The entire benefit consultants community, those that are dealing with clients that are ready to get into self-funded style plans. That's my one, I think that's our nation's last best hope for a group of people that are motivated, that care about prices, is really on behalf of self-insured employers. The government does their own thing. And if you're fully insured, that's that world. It's really about employers that are taking some risk.
I'm interested. So obviously you worked in Hollywood. For those of you who don't know, Jim was a producer as well that he didn't throw on the end of that. And obviously you deal with some unusual contracting side of things. Um, Make for me the connection of how you make the jump. You're working in Hollywood. I want to do the price transparency, and I know you've told me in the past that there's some parallels there. I'd love for you to touch on some of the parallels you see between how the financial side of the movie and Hollywood business works and how things work in healthcare.
Yeah, thanks. It really is oddly true that it is the story of oligopolistic behavior by a small set of powerful dominant firms. It's Econ 101 or 102, whatever it was called when we took that kind of approach to thinking about the world. So you've got in Hollywood a number, historically, they've been around for decades. They're the household names. You've got Disney, Fox, Paramount. You've got a collection, about six of them really, of major studios. And if you look at the history of film and TV, they grew from vertically integrated film production, distribution, and even exhibition. They owned theaters at one time. And then, TV comes along and they get big into the TV business. Now, most of them own a major broadcast network. And at every stage of evolution of the film business, studios have been there in a dominant role. Even though, at the very latest chapter in the last 8 years, Netflix, sure, comes out as the innovative small company and they are a major player and they do have a singular story about how they stand alone. But every major studio now that has a meaningful back library of valuable films is taking those films away from the Netflixes of the world, and they're all creating their own owned and operated streaming services. So the parallel, we've got about 5 or 6 major BUCA carriers that through their contracts, their networks, and their relationships, dominate completely, in my view, how commercial insured members are provided healthcare. And then the business underlying that gets to be really similar. The contracts that I negotiated with major studios, they're long, detailed, complicated. If you want to understand or share in certain cash flows and expect payments when you're expecting them, you are going through a labyrinth of detailed contract language with a bunch of side turns and exclusions and issues that I thought rivaled nobody, because there's all kinds of shenanigans that happen in healthcare and in entertainment, and big studios dominate. No one has good negotiating strength against them. So I thought we won for the most convoluted, complicated, one-sided contracts. And then I started learning about healthcare, and healthcare puts everybody to shame for how awful contracting and complexity is built in as a intended advantage. So it's really bizarre, but interesting comparisons.
Okay, so you say intended advantage. Have you gotten to yourself look at any of these hospital contracts, or is this just your observation as from what you've seen from the transparency data?
Yeah, there's 2 levels. Certainly from what I've seen in the transparency data, at more of a macro level, there's just no question that when you look at a hospital and they have 45 prices, meaning one for each network or contract they've made, 45 prices for each line item, 15 to 20,000 line items. Managing that kind of complexity, or knocking on the door as a newer, younger entrepreneurial entity and saying, we want to access your hospital at a fair price. The transaction costs of getting into that business are terrible, and power goes to the incumbents who've had a deal in place for years, and they can say, well, for next year, let's tweak these prices a little bit and roll on. Now, there are some efforts out there to sort of, and I'm only talking here about payer provider contracting, but there are some efforts to simplify and standardize that. And then you asked, was it firsthand? Not, part of what I've learned as well was, reading and talking to researchers like David Schenker at Stanford, who wrote an interesting paper about the benefits of standardization of payer provider contracting. And he cited in there studies that have shown that the billing and insurance aspect of every claim eats up about 28 to 30 cents of every claim dollar. So, and then let's compare the method, how most of us pay for things. I wish I had one around here. They're little plastic cards. We call them credit cards. credit cards, you go to the store, that is about a 2.5% transaction cost. And even that is high. There are, the electronic services that are out there will probably put some pressure on the credit card companies. But healthcare would be thrilled to have, and not thrilled, they would be.
Jim, just an anecdote. Aren't the credit card transaction fees in Europe like fractional, like 5%, 0.75% compared to the ones in the US?
Yeah, they're in that sub 1% range. Yep.
Yeah.
So, and I'm not an expert in payments, but I'm about to give a talk in a couple months to the UCLA Anderson School of Business, where you got a lot of like bright young MBAs who are thinking about transaction efficiency and payment costs. Well,
Right.
sure, you can make a mint if you can take credit card fees from 2.2% down to 1.1. What if you could do something in the billing and insurance payment system in healthcare? I am not an expert in it. I just believe it is an opportunity, but we can get into this if you want. As we know, incentives are rarely aligned and present in the way they should be in healthcare. If the incentives were right, we would never have 28 cents of every claim dollar going to billing and insurance related matters. It's insane. But it's these fundamental problems and alignment of incentives that are at the core of this. And I suppose that's also what got me into pricing, is that if prices matter, we'll get incentives more aligned properly, and maybe efficiencies will matter. And then we'll do billing, we'll do coding, we'll do payments and adjudication. We'll do a lot of things differently if we could get there.
Okay, so you're working there. Was there any specific event that was like the genesis of you saying, all right, like I need to go hop into doing something about healthcare costs? And then what were you up to? Like, help me understand the timeline, because I guess I don't know exactly.
Well,
So what was the timeline from like Hollywood producer over to hopping into this business? And,
I, having spent, a decade and a half in Hollywood, I appreciate the value of a good story. And every entrepreneur likes to say, my mom went into the hospital and this happened and we felt it personally. And I'm going to buck the trend, and maybe my own good knowledge that a story is the thing to have. I'll tell you how I got into it, but I really don't have a strong personal
that's fair.
story other than a real belief that this is so big. We spend twice, per capita on what other countries do, and that we're spending, 20% of our GDP in 17 states, not just healthcare, but in 17 states of the US, hospitals are the largest employer. So, it really came to thinking, I'll give you the timeline, after it was really probably around 2018 to 19. As I am getting to a place where the stories I wanted to try to tell, the types of shows I would have wanted to produce, and I was in the non-scripted reality TV area, very exciting, very dynamic, but there's a certain sameness to a lot of it. And the things I wanted to do, there was a narrower and narrower scope for those things. Sure, you could just do another dating show or something like that, but I lost some interest in that. And I started trying to think about, well, where are there really big challenges? And again, 10 years of conversations with my wife about her experiences, in healthcare. Met a few people, at the local academic center, UCLA Health, because I met a couple people, and then they hired my company to do some interesting video-related projects for them, and so I learned more there. And it just came around to thinking about. I can say this for the entertainment business. It is functional. It's efficient. Incentives matter. Economics makes sense. And it is, roaring along like a freight train, but it is evolving in a way that responds to the market. Healthcare doesn't and hasn't evolved. So I got fascinated by the bizarrely wicked challenge that is healthcare in the US. And a part of me thought, I want to get involved in, an industry that I think will kind of convulse, an industry that is not on a smooth path of innovation and change and growth and efficiency and all those trends that happen everywhere, and that, Silicon Valley companies have propelled in a lot of ways, a lot of efficiency gains, but none of it happens in healthcare. It's this bizarre sclerotic, I'm not saying that word right. It's this behemoth that is stuck and impenetrable. And then that became fascinating. I kind of like the idea of industries that are problematic and should convulse and change in some radical way. And, you know, a lot of people have said, well, good luck. We've been expecting that to happen in healthcare for decades. So, you know, we'll all be in our retirement homes by the time it happens. But obviously, you know, the things we've enjoyed doing together, neither of us and probably nobody on our webinar call here believes that, or we wouldn't be here.
Well,
so changes ahead.
I know this isn't like necessarily in the direction that we discussed last night, but let's humor me for I think you'll enjoy this. We'll get off into a little bit of a tangent here. So, what about it of that? Like, and once again, I would love if you throw some parallels back into Hollywood and the weirdness of their financing structure. Like, I have my thoughts on what it is, but what is it that makes healthcare so much weirder from the fundamental basis of the economic system than every other economy in the world, in your opinion, Jim?
Oh, wow. I think it kind of there's so many ways to answer that. It kind of comes back, I think, to fundamental incentives and prices. Is just how, you know, it warps an entire industry when everybody can capture value and not really have to maybe provide an equivalent value in exchange. Maybe the picture I paint for some people kind of goes like this, and you've literally been there around these tables, you know, but imagine the distance between an employer that's paying for healthcare and their employee as a patient that receives it. And you look at everybody in the value chain. You start with the employer. Great, they're paying. Next to the employer sits a health insurance broker. Next to that broker sits the health insurance company whose services that broker sold. Next to the insurance company and following the money flows is maybe a PBM and a hospital system next to the PBM. And next to that hospital system is the IPA, Independent Physicians Group. And next to that person is the actual doctor or clinician. And then you look at every single person in that chain. Every one of them benefits when prices go up on every level. And so, while almost everyone I've met, bizarre conflict I have in my mind, everyone I've met on the clinical side of healthcare are intelligent, hardworking, well-meaning people. I've really never run into someone clinically who's like playing twisted business games. Yet, the industry they work in has business incentives that are completely ass backwards and result in everybody benefiting from a higher price. Around that proverbial conference table, by the time the patient receives care, everyone benefits if prices go up, except of course the employer who's paying, and maybe except the employee member if they have a high deductible. Otherwise, everybody gains. Yep. So it's weird. And so here's another, I guess, kind of crazy comparison to Hollywood. Hollywood has a number of people that are in the rank and file trades. And I've met great, makeup artists, camera operators, sound engineers, editors, equipment truck drivers. The vast majority of the people who do the heavy lifting and work to create all of the output of Hollywood are really cool people. They're hardworking, decent. They like rolling up their sleeves and doing a job and doing it well. Yet, the enterprises that are global conglomerates that dominate the business get to be those things because they take a very different business approach into how they can extract maximum value from every point in the value chain. So I see healthcare much the same way. I'm sure there are some exceptions to it. I just haven't met them. But clinicians as a group, really cool, dedicated people. Big, giant national enterprises that are extracting value at every point they can. I don't know enough of them personally, and probably personally they're not bad people, but you get an ecosystem that drives big companies in a certain direction that is, I think, plainly harmful and a threat to the US economy when 20% of our economy is devoted to this stuff.
Well, and I agree with that, Jim. And I think the most alarming part of that is that in the year 2000, it was barely over 10% of our economy was healthcare costs. So I think just that increase over the past 22 years is the most alarming part of that whole thing, that it can go from 10% of our economy, which is roughly on par with the rest of the world, to being double that, which puts us well ahead of the rest of the world in terms of just how much of our GDP is just being kind of wasted. Because if you think about healthcare as a purely economic good on a competitive basis, country to country, you're not getting any value in terms of your market competitiveness against China, against the European Union, against South Korea or the emerging markets. Yeah, it's a net drag on the overall value of your economy, like how much it costs you to take care of your people for their healthcare.
Yeah, it's absolutely true. And I appreciate that from the ordinary consumer point of view, you think of healthcare about the point of care when you go in. And they would respond and say, but all the doctors and nurses are doing great things. That's not waste. I agree. That's not waste. But what people don't, what people aren't exposed to is what is the estimate? 31 to 33 cents of every healthcare dollar actually goes to clinicians. So I do remind them that, is it waste or is it value that you have a grand piano and a waterfall in the lobby of that beautiful hospital? And then across town, there's another glass tower going up for an expansion of another hospital. There's a lot of things we could list off, but yeah. And so, well, the big trajectory of all this is not good. And to all those people who've said, it's funny because when I do meet people who've been in healthcare for 20 years, they just want to get out, and I appreciate that. But those who say, look, it's needed to change for decades, and good luck, it may not change, in the next few years. Well, the definition of unsustainable is something, it has to end. We know that the cost growth on a macro level is unsustainable. So there is a point where it ends. We can't go to a country where we spend half of every dollar on healthcare. And
No,
we can't get near that. We get 25%. Yeah. So, yeah, something will have to change. We just don't know the point. But
we don't know the point, and we don't know how the change will look. I mean, and I look at it, and we'll kind of get back into it here. Just wanted to let everyone know what my thoughts were on what I mean by what makes healthcare fundamentally different from everything else. And I would say the supply chain that Jim just identified and the way that it's paid for is a third-party payment system, i.e., you're not consuming any of the products directly. You're consuming the products with an insurance plan. And really, the only other aspect of our economy that functions in that way, in any way, shape, or form. I mean, obviously, you have like work comp. That I can compare it to is auto body work is the only thing that's close. Now, but the biggest difference between healthcare and work, and I think everybody here has probably experienced. You take your car directly to Mako, and you ask them to do something cash pay via paint, they'll probably be charging at least, like you said, about 30-40% more if they have to deal with the insurance company than they will if they don't, and they can just get it done and waste a lot less of their own time and pay cash. Now, there's still one other factor that isn't true in auto body claims that isn't true in health insurance, and that's that we the consumers pay for the premium on that directly. You and I are I pay for my auto insurance premium every 6 months, and it just gets ACH right in my bank account. So I pay attention to how much I'm spending on that.
Yeah.
Versus when your employer is picking up 80, 90, 100% of the cost of the tab versus, and also what we did, after the ERISA Act with the HMOs, I'm sure you were around in the 80s, Jim, where like all the plans were $20 and you went in and it was $5 or $20 and that was all you ever paid, no matter what. And so then the hospitals can go sit there and set a claim, and the consumer literally has zero concern whatsoever to what's being billed, charged, or paid, because it affects their finances none. And what we're seeing is kind of a gross extreme of 40 plus years of that behavior, obviously escalated very badly in the last 20, and in the last 12 to 15 it's just gone berserk. And that's really what I see is it's a long-term genesis of that kind of situation where it's not my what, and it's my employer's problem, and thus we can claim as much as we want and I don't have to care about it.
Yeah. And I think that there is a big distinction that was lost economically is sort of the role of insurance. So your comment, I can only extend on your good comment about, the auto body comparison. And the extension here is the frequency of occurrence.
Yep.
If we're all lucky, hopefully it's a few years, or for many of us, maybe it can
I
go
only
decades.
had I had more auto body claims the last 12 months than I had health ones. I had to go to the stupid auto body shop twice last winter.
Oh, all right. Well, but I'd say for a lot of people, time goes by. Every year, maybe the average person or family, I don't know these statistics too well. I'm much more on the economics, but a couple of primary care visits a year, probably at least, certainly more for a family. A lot of us can go a few years in between auto body claims. And it's not just the claims, it's the nature of what's going on, is that a predictable claim, which is going to the doctor for any number of household flu issues, earache, kid things, all this stuff isn't what insurance is good at or functionally designed to do. We all know this, so I feel like I'm probably just preaching to the choir here, but insurance works great when it's for big unpredictable losses that occur with low frequency. And now we've insuranceized every visit to the doctor, and that has warped an entire system out of shape. So
I agree. Well, okay. Well, I think we can reel this back into from the macro view of what's wrong with the economics of healthcare into pricing, because as we just kind of have covered, the nature of the PPO agreements, as every benefits consultant on here knows, obfuscates what is a price for all the goods and services that we're receiving. And obviously that's a huge part of, what we're trying to do at Exo Health Plans, what, Next Gen Health Rosetta's mission is like, all right, how do we actually turn people into more consumers? And let's actually use pricing in every way that we can easily that's available in the plan. So that's a big driving factor for both of us. So let's get into how pricing transparency, both from the hospital insurance side at the macro level, and then maybe work it down into the micro, how that can, in the long run, create change in that consumer behavior. So kind of start with, okay, you started FireLight Health. What does FireLight Health do, Jim?
Yeah, well, it is a provider of data and analysis of that data for anyone who can use it or would like to use it to cut better deals in healthcare. And if you were just talking about, making better consumers out of ourselves, and this does tell you where FireLight has gone and is probably going, I think that the consumer in the United States has been trained for decades not to think like a consumer in healthcare. And that is a very tough change. I mean, ultimately, when I was in the TV business, it's about consumer behavior change, getting people to change their behavior, change from one product to another. It is about the advertising industry that supports it, all that stuff. And so I know how tough consumer behavior change is. Oh, also talk to anyone who's in the chronic condition management business. Changing consumer or patient behavior is massively tough. So I think FireLight is really pointed toward helping employers, as assisted by their consultants, change their purchasing behavior of healthcare on behalf of their employees, and then bringing the employees and consumers along that path.
Got it. No, that's fascinating. So maybe we should get into, the what kind of projects are you working on with that? And, if you're able to disclose, some of your clients, and kind of talk about some of the journeys that you've been on with them, and in working on kind of the mission of, can we bring pricing to the forefront of the US market on what is healthcare cost?
Yeah, no, absolutely. Maybe I'll take that in two chunks. There's kind of writ large, what's the story and situation with pricing that's out there? And then I'm always really happy to talk about some of the exact types of things that FireLight does, especially for benefits consultants, or for employers if they were, eager enough, or unions for that matter, who want to look at things. There was a union recently that I provided some data to begin to show how they could examine these questions about, are they paying well? Let me just say one thing, I'll get to the macro first, but fundamentally, anyone with a self-insured plan or any consultant advising someone with one faces, what is the plan with its fiduciary obligations under ERISA doing to ensure that it is properly and prudently managing plan assets. If we want to get legal for a moment, we all know those are the key phrases. And I think that the standard is and will grow to be known that plan sponsors have to look carefully at the prices they're paying and where they're spending where they're paying them, and to ask themselves, are there equally high quality alternatives at a lower price available, or I am not doing my fiduciary duty. And it's that fundamental level that plan sponsors and those that advise them have to be thinking at when it comes to running a plan. And that's certainly where pricing can be really helpful. And we can split hairs later, claims data versus pricing data, there's issues there. But maybe for a moment though, should we just tackle the macro? Where is this whole pricing thing at, price data? Because
yeah, I think that'd be great
for anyone on the call to get the reminded of the big picture. So we're almost, this January 1 will be 2 years into the rules that require hospitals to provide their pricing. And there is a variety of views on how much hospitals are complying. And I certainly, they're a client and a tremendous organization. PatientRightsAdvocate.org issues a semi-annual report that reports on compliance. Full disclosure, I do work on that report. I help validate their findings. But in that role, I look at hospital pricing files by the hundreds and look at how they're presented and how close they may or may not be complying. So in that regard, compliance is a binary thing. Are you compliant or are you not? And there's a lot that the rules require, and only about 15 or 16% of the hospitals, according to that report, are fully compliant. But when I wear my hat as FireLight founder and CEO and talk to people about, well, what data is available that could be helpful today, there's a lot of data from the hospitals. You don't always need perfect compliance to have some meaningful data that can tell you something about what is this payer and that payer, what do their deals look like at this hospital and that hospital in my town. So things will get better with hospital pricing data, especially if they adopt some standardization rules to really make those files easier to look at and view. But they're available and anyone can look at them. And the real trick, I think, where companies like FireLight come in, and I'm not the only one doing this, but my little team will, a busy benefits consultant doesn't have time to look at a spreadsheet with 20,000 lines and 40 columns. And that is what you get, and the data is in there. But people need aggregated and simplified data so they can go in and show their employer clients the crazy money they're paying, so they can go, if they're doing a direct hospital contract, so they can sit down with a hospital and say, look, in the aggregate, you are way higher than this other hospital. I want a different deal. Or go to a hospital and say, look, Buka A is getting this deal with you. Buka B is getting that deal with you. A private firm, sometimes we get a pricing on large companies' self-insured plans, like the Whole Foods plans, for instance. So you can go in, if you're cutting a direct contract, you can go in armed with some real knowledge about the deals that are out there and then negotiate the best deal possible. I should take a quick moment and say there's another set of data available for pricing that is just beginning to be mined. Everyone on the call probably has heard of transparency and coverage, and that is a separate set of regulations that apply to the insurance companies that mandates that they provide data files with all of the negotiated rates that they have paid, not only to hospitals, but to any provider, and historical rates that they have paid to out-of-network providers. So it's a really juicy pile of data, especially because the allowed amounts that they've paid to out-of-network providers is really helpful for anybody who has to manage out-of-network member needs. And this data is giant, petabytes of data. If you're going to put it on Amazon Web Services, tens of thousands of dollars per month to store and handle this data and bring it into a database. There are a few companies doing it. A really cool one, I talked to recently that's only been, this data, by the way, is only 3 months old. July 1 was when the regulation first took effect. but there's a firm up in Seattle, a couple of ex-Microsoft executives that are corralling all of this, and there are others doing it too. So there's definitely a community of us, and that's a big, heavy lift, but it promises to also be some really intriguing things. And I could tell you more about that too. By the way, on this January 1, the insurance companies have to provide an online portal that will have access to some of that data. I think on January 1, it's 500 shoppable services have to be available online for at least any member of that plan. I don't believe it's fully public. But as soon as you say any member of Blue Cross Blue Shield in California, you've got millions of people with access to it. So I expect that I'll find a way to see some of that. So anyway, lots of data out there, more coming because of the hospital, the insurance data, and a lot that we can do with it.
Yeah, speaking on that, a lot that we can do with it. I think first and foremost, there's a lot of information out there for our benefits consultants and potential employers, and it probably seems like more information than is palpable at the time. So, what would you say, Jim, is actionable with the information that we've got now?
It probably depends a little on the employer's objective or needs as the consultant is working with them. Where are they in that continuum of being more proactive and independently minded for their plan? So let's go with the one end of that scale, where maybe you have a fully insured small client, an employer, and they're going to tell you right now, I'm not ready to do anything that begins to be self-insured. I'm just going to stay fully insured. How can this data help them? Well, if they're an employer that is small, let's hope that they maybe have their employees in one city or one region. Their employees go to one of 3 or 4 different hospitals, and a consultant might say, well, look, you currently are on this Buca plan. You're with United. Let's see if forget what the premiums would be for Cigna or something. Let's go see what you're actually what they're actually paying underneath that, so that when your employees who have high deductibles go to a hospital and they're paying the first $4,000 of fees, let's see whether they would be better on United, Aetna, Anthem, or Humana. And you can go and look at the individual payer-specific deals made at different hospitals and provide some guidance that might allow an employee at open enrollment to make a selection choice that is better. If you're an employer that offers maybe plans or different things, or you could better choose for your employees which network you want to be in. But moving along from there, once you get into the self-insured realm, then it gets a lot more fun. When the Excel team goes out and talks to people, it's it can be very amazing to see the difference between, in this city, let's look at this hospital where your employees go. Let's look at 10 of the most utilized services, see what the hospital is charging, and then with the things Excel is doing, they'd be able to compare non-hospital based providers, and there's usually massive differences that are seen, comparing those types of things.
Yeah, definitely seems to be a trend. That was fascinating feedback too, I think, for the benefits consultants. Like, because the deductibles and the coinsurance are becoming so high, Jim's right that the network pricing does affect the members more now than it ever has, because if you want to have whatever you're paying count towards your deductible, co-pocket or out-of-pocket max, co-insurance, all that jazz, you have to pay the insurance carrier's contracted rate. So Jim's in Los Angeles, so say if Blue Shield or Anthem has a significantly better discount than does United Healthcare, you could be looking at 10 to 15% delta on the first $3,000 or $4,000 of their deductible when that member is going to see, say the UCLA health system. You could be looking at the member paying 15% less with the Blue Cross over United. And I'm just making all this up, but we definitely notice. I've seen quite a bit of Jim's data, and you can definitely see differences in the different PPO pricings at different hospitals.
Yeah. And then, once you're getting closer to, an Excel plan structure, and you can do some steerage, then the fun really gets there, because you can say, well, let's take a look at things that are more easily steerable and compare, the imaging prices or the ambulatory surgical center prices. Now, the data that's available is hospital data, so you get their side of the equation. And as there's other sources, and most independent providers of labs or imaging or ambulatory surgical center, they're all too happy to provide their prices. All of them want to compete on price, and they're usually proud to do so. So that kind of comparison is really helpful. Both, and it operates them on both levels. Employees with high deductibles feel the pain of it right from first dollar, and employers are thinking about what their share is too.
Okay, so optimal world, Jim, we'll live in best case scenario land here. What do you think the best case scenario is, that in terms of translating all the information in terms of insurance carrier pricing and hospital pricing, and being able to translate that all the way down to the member level, so we can use it, on an Excel health plan or a Rosetta style plan or whatever, to create an actionable event where the member can actually utilize that data effectively?
Well, right now you take a plan, the plan structure for Excel, it's got a great kicker in there that incentivizes employees to be able to say, look, you have no copay, no deductible, no co-insurance. That alone is a powerful incentive. And, from a plan structure side, there may be the question from an employer of, hey, where should Excel spend its efforts to find these big price differentials where we can get, where we can demonstrate that the same quality but at a lower price is available over here. Once that's done, and pricing data informs those decisions, but they can be then baked into the plan design so that people don't have to actually look at numerical price amounts and compare them anymore. It's just, where's the emphasis in terms of steerage, because the employer has kind of done this work, with the consultant. Now, one could go a step further and provide, additional incentives for employees to actually start looking at price. And then it could be very relevant. I mean, you could also tell employees that, hey, you can get a half a day of comp time, or even, it would be taxable, but they could probably say, we'll give you, a $200 bonus if you make a choice that, saves the plan money. But your plan that you all share as employees, you're helping your fellow employee have more money in this plan for healthcare if you make wise choices. And then, a subset of prices that this would take a business that doesn't quite exist yet, but you've definitely had me thinking out, toward the future. It would be plan specific, locality specific, so that employees can really say, this hospital or that hospital that are convenient for me versus other providers in my city, and look at some of those price differences. If an employer wanted to even more strongly incentivize them to do it. But I think the first step is, when employers and consultants build plan design right, this is kind of done in the background. And then the only question is, how do you want to incentivize employees just for making the choice? And it's already known to the employer in the plan that the choice is wise from a financial and quality standpoint. And then the employer, then it's only the question is, what's the employee's incentive? And you'll be telling us, or I'll ask you now, isn't it an adequate incentive to have no deductible, no copay, no co-insurance? Or do you want to do more to push the employees a little bit and nudge them along? I don't know.
Yeah, I think what I'm kind of envisioning, just off of what you're saying, is like, as we grow these types of models, if we can understand what that pricing looks like, it gives us a lot more power to kind of positively influence the plans, right? If we know, because I think what you'll find is even some of the BUCA carriers, like it, we work with a medical management company. We had Ross from Alethius on, and they have some PPO optimization data. They have probably 80, 90,000 members on their plans. So they have a fair amount of, paid claims data on, what the rental networks are actually paying when they go in there, which, before this transparency was actually very difficult data to come by. And at some level, their data is a little more actionable than the current database, which is, as Jim, requires someone like you to mine it to translate it back into actionable data. And what I'm kind of envisioning is like, if we have information like that, in addition to, um, the corals, the bundles type of information, it can just allow us to expand the amount of incentives that we can provide, where we can take, our medical management team, provide them with information and say, hey, if member X really feels like they want to go get care from this hospital or that hospital, we know that, United is paying UCLA only, 168% of Medicare for these types of procedures. So if the member, say we're renting UHC's network, and we tell the member, hey, if you're willing to go to UCLA instead of to Cedars-Sinai, or instead of to, USC, we're willing to throw in a kicker for you. And if you want to go there because you don't want to go to the outpatient center, we're still able to meet you in the middle and just kind of grant the member more options. I think that could be valuable in the long run. And it almost could make like RBP kind of a thing again, where it's like, if you know what all the hospitals are willing to accept, that makes reference-based pricing more actionable, because like you kind of have, I'm kind of envisioning someone like building a map, kind of like Coral, with all of the transparency data in it. And it's kind of like, well, hey, Mr. Hospital, I already know that you take this price from this book carrier. So it makes it kind of hard for them to say, oh, well, no. We'll only accept that price for Humana. We won't accept that price for you. It's just, it kind of puts the sock in the mouth for them to be able to make that argument.
I agree. At the very least, compared to having no data, being able to walk in and say, I know you take this price here, so that's at least fair for what we're doing. And, certainly for those, companies that are doing RBP and they have claims disputes, or, they've got to set their RBP price and try to find a reasonable place, all this data can be very helpful. Because you can, we've done a few different things. You can take the hospitals, you could take a selection of hospital prices for high utilized procedures, and then compare those to the Medicare price and see where they are relative to Medicare, and then go in and say, look, all that is too high, but I see what range you're in, and if it's a direct contracting scenario. There's another good thing that the data does, which we've done for people, is again, it's for direct contract. It assists direct contracting in particular, but a lot of times, if you are going to go do a direct contract, it's really nice to sort of understand what kind of deals the hospital historically does as a discount to their gross pricing. And the hospital price data will reveal that, because you get the hospital's gross prices, and then you get the list of, Aetna's PPO plan. And then you just do the simple calculation. You can say, look, it looks like you did for Aetna, you did 68% of gross, except for emergency department services, you're at 72% of gross. And I see what you've done here, but that's a starting point. We want a different deal or a better deal. Or if the hospital insists on doing a deal that is as a percent of gross, it can inform really specifically, what deals they've done. And that can be good too. What other things are interesting? I would also say, maybe as a comparison, claims data, I have a lot of respect for. It is real data of what's really paid, and it has its place. But I was looking at some pricing out of Fort Wayne, Indiana. That's one expensive place to get healthcare. Really? And one of the hospitals there had it was a BUCA deal. And the one thing about, price transparency data is required to be annually current, updated annually, but at least you're getting something that's relatively current. And I was looking at it in February, and I also had the file from the prior year. And this was in the first year that this was, enacted. So I had their first file and second file. And there was a labor and delivery charge that went from about $44,000 to $81,000. And claims data wouldn't pick that up, because for some reason they negotiated a massive step up in a certain area that was out of whack with other things. And
81,000 for a labor and delivery. That's pretty brutal.
yeah, yeah, it was a Buca carrier, and it was one of the few hospitals in Fort Wayne, one of the few in it. And this, it gets to a larger issue. I mean, price data does a lot of good, I think, but it also tells us where competition is failing. And then that kind of brings us also, to policy issues. Is that in the U.S. we don't do a lot with government power to create a competitive market. And when markets aren't competitive, we don't do a lot to apply antitrust rules to bring them back to being competitive. And even if we accept that they are, for better and worse, we don't apply the usual regulation that is often applied when markets are not competitive. So it reveals something about non-competitive markets. And I don't have, I am troubled by what to tell, a benefits consultant who's advising a client who's stuck in a market that has non-competitive hospital pricing. Imagine you go and you have all the pricing and you show them how high they are compared to others and all the good data. And their answer is essentially, yeah, we don't care. We know we're higher than everybody, but we're the only game in town. And then I think the only result is, honestly, it's to do what Excel is doing, is to say, you know what, then fine. You're a crazy ass expensive hospital price gouger. And all we can do is have our patients go away from you into the community where there are independent ASCs and imaging centers and other things, and drive people away from the ridiculous hospitals, the ones that are ridiculous.
Well, and then that's kind of our thesis in the macro scale too, is that, and that's kind of what we found when we did that. Jim helped us. We bid on the state of Wyoming's benefits a couple years ago, last year, and we found some really interesting information. If you remember about the upcharging on lab work and imaging, that was so fascinating about how they were both at over 700% of Medicare. Unfortunately, and we've heard this from other hospital people too, is that they make a lot of money off upcharging small items rather than like just upcharging the larger items as well. We as benefits consultants frequently focus on the big ticket items. Underwriters, especially stop loss carriers, are very focused on the large items. But one of the things that we focus on with Excel, given the style of reinsurance and whatnot that we apply to the small group side of things, the volume of the smaller stuff does matter, and that is a big deal. So, because of course across our block on the small group side, those MRIs, if they're coming all in at 11 grand instead of $600, there's a lot of potential waste there. So I think as we incentivize members to go outside of the scope of the major hospital systems for that care, where you can get it at a lot lower price point for both especially the outpatient surgery and the imaging, those are profit centers for the hospitals. So if those are being moved out of there, in theory, that could create, like, the goal is not for us to like be punitive to the hospital, but to create competition so that if the hospitals want to see those members for those procedures that are more profitable for them, then they need to get more price competitive with the Dr. Keith Smiths of the world, with the Green Imagings of the world, if they want to see the volume back. And I think that's how, we've entertained, direct contracts with EHN, with like Baylor Scott and White and Memorial Hermann in Texas, those types of places. And those contracts want that volume of those procedures back to them, and it's very important. And we've kind of worked with EHN and reviewed their contracts. And you know what the cool thing is that the pricing on those contracts is competitive with Coral's pricing. And that makes me really happy, because it's like, that just tells me that if there's 3 or 4 hospital systems willing to get price competitive with Coral, that more of them are financially able to do so, because they definitely wouldn't be throwing us up direct contracted deals if it was going to result in them shutting the doors from them doing it. And it's not that we're looking to kill hospitals here. It's just give us a reasonable price, and then we're willing to steer people to it. We're just looking for reasonable. No, it doesn't need to be low enough that you're going to be in trouble, or we're looking for Medicaid pricing or something.
Yeah. Exactly. And the first thing we often do is, set the price schedule, make another column on the sheet. What is it as a percentage of Medicare? Because, that's where everybody really gets sticker shock. It's like, okay, we'll pay well over Medicare, maybe even up to 2 times, but you get these hospitals that are 3, 4, 5 times, sometimes higher. It gets laughable.
Yeah, it's when hospitals come to you and say my floor is 5x, and there's no way I can afford to operate if I don't get 5x Medicare. You're like, I'm not sure that that's actually accurate.
Yes. Yeah, and there's a way around it because, by the way, I think those who do direct contracting and get into these conversations, they get that all the time. The hospital says, if I give you the pricing you want, I'm going to lose money. So there is information that we have accessed and provided to consultants through, as a service of FireLight, but it's also out there as well. If one wants to go to the NASHP website, National Association of State Health Plans and whatnot. If you look
that's
at the
Marilyn Bartlett's organization.
Yeah, Marilyn Bartlett developed a tool for them that examines the Medicare cost reports, and it's excellent. It allows you to refute that question because it does incorporate the costs that the hospitals themselves report, and those costs can be compared to what they're taking in insurance. And it allows you to say, no, if you give me a deal at, 180% of Medicare, you won't be losing money because your own data shows that. So yeah, there's a few things that, oftentimes I'd say there's a little package. Frankly, this is probably, maybe I'll give my pitch for FireLight. A lot of times, people want to let's look at the RAND data where we can basically compare the hospitals in your city to others in your state and in the country. Get a big macro picture of how expensive these hospitals are relative to others and relative to Medicare rates. And then let's also take a snapshot of a few of those hospitals using the the Medicare cost report comparison tool. So we can arm someone, a benefits consultant, with that information about, hey, you're not going to lose money if you give me a lower price. And then we can also take a subset of pricing data and really look at actual hospital costs and find out what other deals the hospital has entered into at what price levels with other payers. And that full picture, I think, is a good bit of ammunition for anyone going in to do direct contracting or, RBP or anything else where prices are highly relevant. But I'll say one more thing though too. You mentioned the value of being able to look at across a number of procedures prices, especially the issue of the small ones. It is really true. Like, if I were a hospital, and I want to say this because I hope no one takes it back to them, but if I were a hospital, the one thing I would do, I would take a loss. I would be a loss leader on DRG 470 hip and knee replacement, because everyone in the benefits community cites the hip and knee replacement cost as a benchmark for whether a hospital is fair priced or not. So these hospitals are not idiots. They should probably just say, look, let's take a big loss on that one line item because everybody uses it as an indicator. So you are very right. You can't just look at 1 or 2 or 3 things. And I think someday the hospitals are going to get onto that, and they're going to selectively down price their colonoscopy.
Hey, that's how Costco works. They lose money on the meat because they want to get you to go walk to the back of the store and buy 300 Duracell AAA batteries that'll take you 7 years to use all of them, and you'll probably lose it. And you'll probably lose it before you use them.
Yeah, that's right. Those rotisserie chickens are loss leaders for Costco. Anyway, but yeah, just because getting around, I was speaking at a conference 3 months ago, people love to cite certain things, and that hip and knee replacement is often cited. And I know it's a high ticket item, it's a musculoskeletal issue, but we should pick a few other examples. But the real thrust of it is you're right. You don't want to look at 1 or 2 or 3 things and base your decision about.
You need at least a good solid library of 20 to 30 to make sure you got a benchmark.
Yeah, the high utilization items. That's true.
So, and if you want to plug yourself, please let us know how we can, and we'll send an email out as well with all of your contact information if people want to work with you.
Oh,
have any questions, if you guys want to connect with Jim. And then Jim, do you want to give a plug for patients' right advocates too, or just yourself? Any information about that?
Absolutely. patientrightsadvocate.org, big fan of the organization. As I've said, I've worked with them. Their website definitely provides access to a report that tells you about which hospitals are even willing to step up and comply, and that's patientrightsadvocate.org. And so they're a super cool organization founded by Cynthia Fisher, who is not only dedicated and passionate about the overall issue, but was very involved in pushing for the and achieving success with getting the price transparency rules enacted in the first place. And then, FireLight is honestly one of the beneficiaries of that. We will do, as I said, we do a number of things to help provide actionable, usable data. My theory is get everything down on one piece of paper that you could figuratively take into the room, and someone negotiating with a hospital would have data that they could argue with and push for the deal they want to have. And so, there's a little bit of information out there on us, at FireLightHealth.net. And certainly, through you or anywhere else, it's easy enough to find me, Jim Jusko at FireLightHealth.net, if anyone wanted to email. And that's the state of affairs today, I think, in price transparency.
Awesome, Jim. Fascinating conversation. This will be reposted on our YouTube channel and our LinkedIn channel, and we'll share and obviously tag Jim in there too. So if any of you all want to share this with your clients or just other members of your team to kind of help understand a little more about what price transparency is and kind of its macro effects, feel free. With that, I think we're going to go ahead and wrap up here. Alex, anything else to add? I don't know if you need to hop on here and close this out. Doesn't look like it. So I think we're good to go ahead and just end it. But thanks everybody for coming today. Good luck here in the fourth quarter. Close as many deals as you can and keep grinding, and everybody stay calm. We'll have some more episodes coming up that will help. There'll be kind of special episodes just in regards to account management, implementation kind of things, just things for your support and staff teams as well as yourselves to help us get through the fourth quarter. So thanks for everybody's time.
Thank you.